Good afternoon and welcome to today's COVID Conversations webinar, CCCC Decision Aids, Ventilators, CPR, Transfers, and Comfort Care. My name is Keita Scholl. I'm the Office Manager for the Coalition for Compassionate Care of California. We're glad to have you all with us today. Before we get started, I would just like to take a brief moment to thank these organizations that sponsor the Coalition each year. We could not continue to do this important work without them, so thank you so much. And also, thank you to these organizations for their additional sponsorship of our COVID Conversations webinar series. We appreciate your support. If you have not yet checked out our COVID Conversations Toolbox, please take a moment to do so. The recordings from past COVID Conversations webinars are there, the slide presentations, and many, many tools and resources from many organizations on how to help you get through this difficult time. It is now my pleasure to introduce our presenters today. We have Dr. Karl Steinberg and Dr. Jessica Zitter presenting on the decision aids and how to best use them. Dr. Steinberg is a long-term care geriatrician and board-certified family physician with a subspecialty certification in hospice and palliative medicine and certifications as skilled nursing facility and hospice medical director. Dr. Steinberg received his undergraduate degree in biochemistry and molecular biology from Harvard and attended medical school at The Ohio State University, completing his family residency at the University of California, San Diego. He is the past chair of the Coalition for Compassionate Care of California and editor-in-chief of a monthly periodical called Caring for the Ages. Dr. Steinberg has been a hospice and nursing home medical director since 1995 and is probably best known for taking his dogs with him on rounds in nursing homes, assisted living facilities, and on hospice and palliative care home visits on most days. Our second presenter is Dr. Jessica Zitter. Dr. Zitter specializes in critical care and palliative care medicine and practices at the Public Hospital in Oakland, California. She is the author of Extreme Measures, Finding a Better Path to the End of Life. A link to the book will be included in our follow-up email. Her essays and articles have appeared in the New York Times, The Atlantic, The Huffington Post, the Journal of the American Medical Association, and other publications. Her work is featured in the Oscar and Emmy-nominated short documentary Extremis, which is now streaming on Netflix. She is a nationally recognized speaker on the topic of dying in America. Dr. Zitter attended Stanford University and Case Western Reserve University Medical School and earned her Master of Public Health at the University of California, Berkeley. Her medical training includes an internal medicine residency at Harvard's Brigham and Women's Hospital in Boston and a fellowship in pulmonary critical care at the University of California, San Francisco. In 2005, she co-founded Vital Decisions, a telephone counseling service for patients with life-limiting illnesses. Welcome to our speakers, and Dr. Steinberg, I'll turn it over to you.
Great, thank you so much. It's a pleasure to be presenting today, especially with one of my favorite people, Jessica Zitter, one of my favorite intensivists. Boy, that bio, unfortunately, it's an old bio because I no longer take the dogs to work with me for reasons that are unfortunate but obvious to everybody right now, since we don't want them to be a vector. So we're going to be kind of honing down on a couple of the Coalition's decision aids, and I suspect that a lot of people on the webinar have seen these and are quite familiar with them. We did repurpose these about maybe a year and a half or so ago, and they are basically 4 pages, and we have one on CPR, one on artificial hydration, one on tube feeding, and one on intubation and ventilation. And these are very popular, and for now, they are available at no cost. Normally, there is a nominal cost associated with these, and we certainly appreciate it when you download and pay for them, but during this pandemic, they're being made available free of charge. They're available in English, Chinese, and Spanish, and you can just go to our website. They're fairly easy to find if you go to the coalition website. Next slide, please. So we are going to hone in on the CPR and vent, since those have some specific application to the COVID pandemic. We'll also talk a little bit about the decision whether or not to transfer a resident who's residing in a skilled nursing facility and other locations. For example, can somebody be cared for at home if they were to develop COVID-19 respiratory illness? So let's get right into the CPR tool. Next slide. And this is the beginning of it. These are at a low health literacy level, so they should be no problem for people to understand. They've got some graphics that are also fairly simple, and I think something that we really tried to do this time around was make them completely non-value laden, I guess, and not sort of pushing an agenda, because obviously that's something we always want to make sure is that we are not pushing an agenda and really just helping a person define their goals and make an informed decision about specific treatment recommendations or treatment options. So this explains what CPR is and how it's done. You'll notice that it says on TV it looks like it's quick and easy, but it isn't. That's about as value-laden as these documents get. All right, next slide. So when do people need CPR? Obviously, this is needed if somebody's heart is not providing adequate circulation. And then how might it help if a person's heart has stopped? And obviously, the goal is to restart the person's heart, and that it can help somebody stay alive for the time that that it takes to restart the heart, if the heart in fact restarts. So if there's a treatable condition that caused it, or an arrhythmia or something, that can allow you not to die in the meantime. Next slide. So here's the one about the potential harms versus benefits. And so these are things that probably most of us that are clinicians or that are having direct patient-facing or family-facing treatments or interactions talk about, which is that people do have anoxic brain damage following CPR, following a cardiac arrest. And for some people that will be an enduring problem. They will never get back to their previous, in fact, probably for most. There are, obviously, you can break a sternum, break ribs, and you can have bruising that's short of a fracture, you can get burns, and you can have aspiration. So those are obviously some of the downsides of CPR. And then does it help people get better? The answer, of course, is it depends. And I think it's important to explain that it's not like it is on TV. It's an act of physical violence, but it does have the potential to restore your circulation and prolong life. I think in light of COVID, most patients with severe COVID-related disease won't really derive a benefit from CPR if the reason they had an arrest is because of severe COVID disease, and they're probably already on a ventilator, then only a very small fraction would survive it. And then out of the people that survive CPR, only a small fraction of that fraction is going to survive to get out of the ICU, much less out of the hospital. So this is something that probably should be discussed alongside this, or in addition to these documents that don't specify COVID. And this part of the decision aid says only some of the people who get CPR will live through it, and that living through it, again, doesn't mean that it restores you back to the situation you were in before. Okay, next slide. Jess, do you have anything to say about this? I know you've been doing some palliative care, virtual palliative care consults on the front lines in New York. So anything to add to that?
Well, I mean, I think that, you know, one of the things I think we want to make sure people understand as we go through these two tools is that CPR and getting on a breathing machine, sometimes people think, oh, I can do one but not the other, and they tend to be mostly a package. You know, if your goal is to really do everything you can to try to stay alive, either as long as possible regardless, or for a period of time to allow doctors to try to correct things so that you can hopefully come off of them again, it's very confusing to doctors, I think, to kind of say, well, I would do one but not the other. And so I guess that would be something I want to make sure we clarify to people, that sometimes we make it too confusing by separating CPR out from a ventilator. Karl, what do you think? Do you have anything to say about that?
Yeah, I think that's a great point. And, you know, out in the field, I mean, in the ICU, there's a lot of different options that we don't have, let's say, in a nursing home. But I think that's part of the reason why on the POLST form, if you check yes to CPR, you automatically, you have to pick full treatment, which means, yes, you get intubated. People want to sometimes pick and choose specific items, and I think in real life it's not always that easy to do that.
Yeah.
So okay, next slide says this is who is most likely. Sorry, go back to the last one. You had already. Okay, who's most likely to be helped by CPR? Obviously, younger, healthier people, and people who have a witnessed arrest, or you know, who get CPR started very promptly after the arrest. And people who have shockable rhythms, obviously, are much more likely to be helped. Less likely to be helped, people who are seriously ill from heart, lung, liver, or kidney failure, people who are already suffering from some other terminal illness like cancer or end-stage dementia, and just in general, people who are older, weaker, or very frail. So, you know, it's recommended on the form that people ask their doctors or other providers about, you know, discussing risks versus, or, you know, burdens versus benefits of providing CPR. But these documents can be very helpful in just setting up those conversations. Sometimes if you give them beforehand, it can be very helpful. And again, if somebody suffers a cardiac arrest because of COVID-related respiratory complications, they are extremely unlikely to survive CPR. Okay, next slide. And this is just a little graphic of the survival numbers. This relates to a 30-day survival, meaning that the person is still alive, but not necessarily that they're out of the hospital or out of the ICU, or mentally alert, able to walk, continent, or any of those other things that might be a factor in whether somebody would want to submit to this type of invasive intervention. And as you can see, not surprisingly, the statistics for people who reside in a nursing home or who have serious chronic illness are a lot worse than young, healthy people. And I think these statistics are things that a lot of the public finds surprising. The fact that even in a hospital, when you have an arrest, survival at 30 days is less than 1 out of 4. And that's based on a lot of kind of large-scale studies. Next slide. So this might seem obvious to most people. What happens if I don't get CPR? Well, if your heart stops beating and you stop breathing and you don't get CPR, you're going to die. But if you're having other types of symptoms and you say, I don't want CPR, but I do want other treatments, you can, for example, say, yeah, I want full treatment. I can be DNR on a POLST form or no CPR, but I can still opt for full treatment, which means if I go into respiratory failure, yes, I want to be put on a ventilator. And that's not that unusual. You know, our COPD population, a lot of them say, yeah, if my heart stops, I don't want to be have chest compressions and that. But if I'm having
Oh, sorry to interrupt. Sorry, I just wanted to clarify. I think that's right, and that's an important. Sorry to interrupt you, Karl, but I think it's important for people to understand that you really wouldn't do cardiac or CPR without being willing to get put on a breathing tube. But you might get on a breathing tube and still say, but if my heart stops, I don't want to have cardiac resuscitation. They still typically tend to go together as a package, but you could make that differentiation.
Yeah, and so that's if somebody decides, look, I don't want CPR after reading this and seeing that it's not very effective and that it can, cause significant harms, then obviously the next conversation is about what you would want short of CPR if you get into problems. So that's what this is about. Okay, so next slide. There's a few slides, a few portions of our decision aids that help people decide. You talk to your doctor, does your doctor think CPR would help you? What's the likelihood that it would help you? And, how might it harm you? And also, how might it help you reach your goals? Well, whether that goal is getting back to a certain functional level or whether it's, getting to my daughter's graduation or whatever else they might be holding out for. What are your chances of living at home after CPR? How likely are you to survive it, and what life might look like? And again, if somebody suffers a cardiac arrest because of COVID-related respiratory complications, they're unlikely to survive CPR, much less regain their previous level of cognition or functional status. That doesn't mean that everybody won't want it, but I think in light of COVID, that should be part of the discussion. Next slide. So this says what type of people say, yes, I want CPR versus what kind of people say, I would prefer not to have it. And in general, people who are more ill and already have a limited life expectancy are more likely to choose no CPR. And then this recommends talking to family, close friends, your doctor, possibly your pastor, and other trusted advisors. And whatever you decide, this form recommends creating an advance directive, which of course we recommend that for everybody, whether you're healthy or not healthy, to designate the person that will make decisions for you if you're incapacitated. And as you're all aware, that's probably one of the most important things that we can determine as part of our advanced care planning conversations is who do you want to make decisions for you. This does call out PULSE specifically because if somebody doesn't want CPR, first responders are not going to obey that unless they've got a doctor's order, which is usually in the form of a PULSE or sometimes a DNR. And then it directs people to give copies of them to their families, doctors, and their local hospitals and so on, and keep them in an easy-to-find place. So next slide. And this is more the same about, who should you have these conversations with. Obviously, it's really important to talk to anyone who you might designate to make decisions for you. Also, any person for whom you are the medical decision maker. You obviously want to know what that person would want. How often do we see, a spouse that gets named on a power of attorney for health care, and then we ask them, what should we do? And they're like, gosh, I have no idea. We never talked about it. So that's a good lesson for us to take in our encounters with people is to make sure, don't just put somebody's name on it, but make sure that it's the right person and make sure that person actually knows what you want. Again, at the bottom there, it says if you don't want CPR attempted, then you'll need to ask for special medical orders in the form of a PULSE form. Next slide. So to summarize this CPR portion of this talk, CPR is not as effective in real life as it is on TV. Nursing home residents in general and those with COVID-related respiratory failure specifically are very unlikely to have a good outcome after a COVID-related arrest. And I think it's really important for people to understand, this is one of my biggest take-home points, is that when people sign DNR or no CPR on a PULSE form, that does not mean just let me die. And that's even sometimes still a misconception among healthcare providers. So it's no wonder that people in the lay community, they're like, oh no, I don't want to make my mom a DNR because I know what that means. That means you just let them die. That means, you know, if you walk into the room in the nursing home and she's gasping for breath, you're just going to walk out because she's a DNR, which is totally wrong, obviously. DNR on a pulse form only relates to when the person has no pulse and is not breathing, which at the Ohio State University for Medicine, the Ohio State University College of Medicine, I learned meant that if you have no pulse and you're not breathing, that you are dead. So, you know, if you frame it as, if you sign this, this just basically means if you find me dead, don't try to bring me back to life. Sometimes that's, people understand that a little bit better. So I think those are the important aspects of that. Jess, anything to add? And then I'll turn it over to you for the ventilator.
All right, I was muted. I apologize. I really want to, I really, as someone who's out there taking care of patients in the hospital, I want to really reiterate how important that is, that we do not, you know, DNR, making yourself, you know, do not do cardiac resuscitation really means nothing to many of us, to most of us physicians, and certainly in hospitals that understand the concepts of palliative care, that it means really to focus still very aggressively on taking care of patients. So it's just that final act that we are saying is not a part of the picture. So this makes me so sad that it's so confusing and that people still don't totally feel that they understand or are comfortable with that. But I just want people to understand that for me, a DNR, knowing that somebody does not want their heart thumped on if it stops, in no way decreases the interest and desire to provide aggressive care, whether it's towards managing symptoms or any other type of medical interventions based on what is consistent with the patient's goals. So I hope that that's clear to people in the group. And the same thing goes for the ventilator.
I just want to say one other thing. You know, with COVID, there's a whole nother sort of layer, which you can probably speak to better than I can as far as CPR, but obviously somebody is suffering from COVID disease as far as PPE and making sure everybody's fully PPE'd before starting CPR. I think that's another important aspect, that there may be more of a delay, especially in non-hospital settings.
Absolutely. I mean, it takes a lot of time to put the protective equipment on, and if somebody is having a cardiac arrest, even a delay of a few, you know, of 30 seconds can mean precious drop in outcome. So it really does make it even more, you know, unlikely that somebody who has suffered a cardiac arrest is going to come out of it in any kind of with any kind of serious functional capacity. That people are very likely to come out of that, if they survive it at all, which most don't, with serious neurological damage. So shall I move on to the ventilator tool?
Yes.
Okay. So first of all, hi everyone, and to Karl, it is a pleasure to present with another poodle-loving person. So ventilators. What are ventilators? You know, ventilator is basically a machine that has a bellows, that has a compressor, that can actually take a couple liters of air and push it through a tube into your chest cavity. The ventilator is connected to the patient through a tube, you've heard the endotracheal tube, a tube that goes from this machine down into your trachea, and so that it can push the air right into the trachea, and then it can inflate your lungs. And when do we talk about putting people on ventilators? Well, there's, you know, people can start to go into respiratory distress for a variety of different reasons, which we'll talk about in a later slide. But when your body, your own personal ventilatory system, all of your muscles that you know work to inflate your own rib cage, that's the natural bellows, is the rib cage. And if you don't have the ability, because of neurological compromise or because your body just can't keep up with the work, because your body's too fatigued and can't keep up with the work of that ventilation and just is giving up, the ventilator then takes over as the sort of the artificial bellows that your own chest wall usually is. And so the way that someone is attached through that, using that endotracheal tube, is that the tube is placed through the mouth and the nose into the windpipe, and then this ventilator pushes the air through. Now, medicines are definitely given to make the person sleepy. It sounds terrifying to have somebody, you know, open up your mouth with a tool that then allows them to thread this tube into the middle of your chest cavity, but we almost always give, in fact, every single time we should be giving significant sedation and sometimes paralytic medications, just so you know, so that your body's not fighting the tube going in. And again, you would never give paralytic medications without having someone very sedated. So those two things happen in order for the tube to be placed into your body. And then when people are on that breathing machine, most people require some sort of sedation, not paralytic for the most part, although some people, because their lungs are so bad and they're still fighting the ventilator and it's hard to ventilate them, they still need to be paralyzed. But those people, again, would be very heavily sedated. But then other people, most other people, even if they don't require the paralytic, will require some sedation medication just to keep them calm. So when do people need a ventilator? Well, again, I described before, people whose bodies just cannot keep up with the work of breathing because they're overly fatigued, or because their oxygen their lungs are not filtering in oxygen that well, and so it just requires extra work and their bodies aren't strong enough to keep up with it. Or somebody who has had some kind of neurologic compromise, so that they're either quadriplegic, for example, or somebody who just has a worsening neurologic disease like ALS, who just cannot keep up with that strength required. A very, very bad pneumonia sometimes can overwhelm a person's ability to keep up with the breathing, or pulmonary edema, which is fluid on the lungs, or somebody in the middle of a very serious heart attack. All of those kinds of situations sometimes require the support of a extra bellows, whether it's a breathing machine with the tube going into your lung, or something that we call non-invasive ventilation, where a mask is tightly placed onto your face to, again, push air from that machine into your lungs. So the reasons obviously, if you're going to have a surgery, you get intubated because they can't have you breathing on your own. They have to have complete control, and you have to be very, very sedated for surgery, and you will require support from breathing. So people with surgery, who are getting surgery, usually have a pretty short-term ventilator support. A serious injury, like a car accident, sometimes, again, someone's ribs are broken or something and they just can't keep up with their breathing, so they'll get intubated, and that can often be very short-term. Other types of lung or heart disease, like a COPD flare, emphysema flare, or asthma flare even, or again, I mentioned a heart attack, or sudden pulmonary edema, fluid in the lungs from your heart not working very well. All of those things can sometimes, you can get the breathing machine in, and the medicines can work pretty quickly, and you can come back within a day or two and hopefully get that tube out and kind of be generally where you were before. However, long-term ventilator use can often transition into a long-term picture. I mean, you think about all of those people whose lungs are kind of on the verge because of emphysema, or their hearts are kind of on the verge and they kind of go in and out of pulmonary edema. You can use a ventilator to hopefully turn them around, but there will come a point when that person's lungs or heart or neurologic weakness has gotten to a point where they are no longer able to come back to a place where they can independently breathe, if that makes sense. So short-term ventilators can sometimes turn into long-term ventilators, and that's where things get very, very tricky, because it's hard to know, if you got intubated 3 times over the past year for COPD flare, and each time you got off the breathing machine, you kind of expect that you're going to get off at the 4th time. But unfortunately, there will come a time when that is not true. And it's hard to know when that time has arrived. And so a lot of times in the intensive care unit, we have patients who have had multiple intubations over the past year or 2 years, and we come to this point where we can't pop them off the ventilator again, and we are at a point where we have to decide at 2 weeks whether or not we're going to do a surgery to attach them through a trach in their neck, a surgical incision, so that the tube doesn't go through their mouth anymore into their lungs, but it now goes through their neck in a surgical trach. And that is a more stable connection to the breathing machine. And when you get to that point where you've trached somebody, then you're in a whole different league. Because the honest truth is, you're in a place where it's harder to ever come off the breathing machine. And I'm not saying physically harder, I'm saying emotionally harder. That surgery, that trach surgery, is a big moment. It's a surgery. It's, you know, and you've kind of gone and done this thing to somebody. And the idea of saying, well, okay, we gave it another week for 3 weeks now, and the person still isn't seeming to be breathing on his own, it's a very hard thing to say, well, let's just disconnect that thing that we put all that effort into creating. And so people don't, once they've actually had these surgical connections made, whether it's for this breathing tube, or the same thing would be true for a feeding tube, it becomes more of a permanent situation. And people have to understand that. In my book, I talk about the 2-week trach point, because it's a really important decision and can commit someone to a life on a breathing machine. So again, the long-term ventilator, if a person had their chronic illness that has just built to the point where they just don't have a point of ever being able to come back off, or just understand that with a person who is getting progressively frail from different kinds of illnesses, when you go on a ventilator, your diaphragm, which is the most important muscle of breathing, is all of a sudden completely inactive. And like any other muscle that isn't getting used, it gets flabby. And if you have a person who's chronically ill and you allow their diaphragm to go for 3 days, 4 days, 5 days, 2 weeks, 3 weeks without being used, it just puts them that much more unlikely, makes them that much less likely of ever coming off the breathing machine. So I think now, and one more category of patient for whom long-term ventilator issues are really important to consider is somebody who has a very serious neurologic compromise, whether it's because they were in some kind of they had a head injury in an accident, or they were so sick from sepsis that their brain stopped kind of functioning well, or they had probably the most common is somebody who has who had a cardiac arrest and got resuscitated and put on a breathing machine, and we don't know if their brain sustained irreversible damage. Those situations are very common in the intensive care unit. And a lot of times people say, well, wait a minute, we don't know, maybe he's waking up, maybe he's not waking up. And we get to that 2-week point, and people then put them, the families just feel like they can't just take this out and let dad go. They have to see if he continues to improve neurologically. And a lot of those are patients who go on to live for the rest of their lives in long-term acute care facilities. Do people ever have a miraculous awakening and go back to their life the way they were? Yes, but it's rare. It's rare. So I'm sure there will be questions about this, but we should talk about that, because it's a very, very important thing when you actually make that decision at 2 weeks. And with COVID, by the way, it's longer, because they won't do a trach on a person who's still testing positive. So we have patients, some of the patients I'm taking care of in New York have been intubated for 3 weeks. They have not been trached. They still have an endotracheal tube because they still have COVID positivity on their test. So it can get complicated with that. Let's see, next slide. Benefits versus, I think I'm gonna have to speed this one up, and I'm sorry if I'm talking too much here, but the benefits versus the harms. I think I've kind of covered some of these. How might it help? Well, we just talked about it. You might, get on the ventilator and it will allow your body to correct itself, whether it's from a COPD flare, an asthma flare, a pneumonia, or even a stroke. And you kind of can get back to a place where you could come off the ventilator. And obviously that's a huge benefit for somebody who would have died otherwise. It obviously allows people to have surgery who wouldn't otherwise have surgery. And for some people who've had a spinal cord injury or who have progressive neurologic damage and wish to remain alive, even if it's connected to a breathing machine, that would be a way to allow them to stay alive for longer. Now, how might a ventilator cause harm? Well, I just explained to you about this idea of if you don't ever wake up, to a condition that would be acceptable to you, then the biggest harm that we can talk about is that possibility that you have been attached to a breathing machine through a surgical connection, a trach, and that will never get disconnected. That whoever's around you, even if you wanted it to be disconnected and you didn't want to live that way, that people would just, that you would sort of be committed to that path of living in a long-term acute care facility, which can be, most people surveyed say they would not want to live that way. It's a very rough life that I think people don't understand what it looks like when they say, yes, I'll have a trach. And I'm a firm believer that and there's nothing wrong with wanting to get a trach, but you need to understand what might lie on the other side of that decision so that you can really make the decision that's best for you. Again, what does life in a long-term acute care facility look like with a trach and a feeding tube, which is becoming more and more common? Chronic critical illness is the name of that syndrome. And we have more and more people all the time living in long-term acute care facilities in America who really live there. It's a lonely existence. The reality is a lot of, most of the time they spend alone. Some families, it's a long haul. It's a marathon, and these bodies, are not often moving, and so they can break down and get a lot of decubitus ulcers. And we often see in the intensive care unit people coming in and out of these long-term acute care facilities with terrible septic shock from skin infections, pneumonias, and urinary tract infections. So it's a very hard reality that I always feel bad telling people, but I just feel that people really need to understand what that is when they think about doing a trach. So whom does it help? Well, obviously a ventilator will help people who are going to recover back to a condition that would be acceptable to them. Who is less likely to be helped? Well, the people who are more at risk for not being able to pop back to a place where they could come off the ventilator, and those are people who have chronic illnesses like the things we talked about, COPD, asthma. Well, asthma is different, but COPD, congestive heart failure, progressive neurologic diseases, those people are going to be more likely, especially as they get sicker, to get into a situation where they will not be able to become liberated from that ventilator again. Terminal illness, certainly metastatic cancer, frailty, weakness, advanced age, advanced dementia. Those are all situations where patients often end up having to stay on breathing machines, or I can't tell you how many patients with advanced dementia we get in our intensive care units who are really, the question is, before they became demented, would this have been a life that they would have wanted? And that's a question that everyone needs to process. Would you want to live, attached to machines, or spend even 2 or 3 weeks on a machine if you were very, very demented and confused? And again, these are all the things I want us to all be having conversations about all the time. Next, what is it like to be on a ventilator? Well, as most people can't talk, drink, eat. They're usually sedated, but not always. And I think that there's a lot of emerging evidence that there's a lot of trauma that comes from being ventilated in an intensive care unit. It's a very frightening experience, even though we do our best to keep people so relaxed and sedated. Medical teams should be very attentive to patients' anxiety levels and trying to titrate medications as needed. I would say that the honest truth is it doesn't always happen the way it should. And I think, again, the trauma of an ICU experience on a ventilator is not an uncommon thing. And I think, again, we need to do our best as doctors to make sure we are doing everything we can to mitigate it. But it's an unfortunate reality of the experience. So again, once someone is on a ventilator, can they come off? Yes, of course. And that's our hope, is that, of course, our hope is always that people will come back off the ventilator. And not only that they'll come off the ventilator, but that they'll be able to go back to their lives the way they were. The unfortunate reality is, just as you saw with the slide that Karl showed before, is that the sicker and the more chronically ill, the weaker a person is, the less likely that is to happen. The idea of a trial period, you can see here in parentheses there, is very, very important concept, because a lot of people might be helped by a ventilator, but they might not be, and you don't know until you've tried. And so there is on the post form, and Karl can speak to this, an option to say, yes, I want you to intubate me, but I want it to be a time trial. I do not want this to go on. I don't want to be trached. If it's not working in 2 or 3 days, if the doctors don't think that I'm likely to bounce back to whatever quality of life it is that you deem essential, you can do a time trial. And I think that's a very important thing. And if anyone wants to talk about that afterwards, we can. Next slide. So LTAC and tracheostomy, I think I spent a lot of time on that. So I don't think we need to talk about that. I covered that pretty well. And then the next slide, what if I don't want it? Well, that, just like we mentioned about the CPR issue, if you don't want it, you will get other treatments. You will get aggressive other treatments. I highly recommend that palliative care be involved in your care, whether it's at home. If you're seriously ill enough that you're being considered, if you are considering a ventilator and you decide you don't want it, then you probably will benefit from having the types of palliative support, even to aggressive continued treatments, just to make sure that we're always taking the best care of you. And I will tell you, I am a proud palliative care physician, also proud ICU doctor, and I'm really aggressive about taking care of people. And by the way, that includes sometimes encouraging people to have more aggressive treatments than they want, whether it's chemotherapy or getting intubated for a trial. So what you hope is to have a team that is not going to be just looking at a checkbox of yes, CPR or not, to take the best care of you that they can, and that they're going to be focusing on you as a person with your preferences and your values to match all the different interventions that are going to happen with you, to make sure that they're all ones that are consistent with what is most important to you. So yes, of course you can still get other treatments, and all of that requires good communication and clarity between you and your team and you and your family about what is important to you and how you want to be cared for. But again, this bottom point, remember that the tube, the CPR, all that stuff, we think about it as, oh, well, it will prolong life. No, that's not true. If someone is sick enough that their heart stops, or it's sick enough that they can't breathe on their own, these things often don't prolong life anyways. And so it's really important to remember, unlike Grey's Anatomy, that this stuff is not miracle stuff and often can cause far more damage and suffering than would happen without it. And I think that's really the key part of the planning here. So next slide, how to decide. Well, we've again talked a lot about this, but it's really going to be important that you talk about your acceptable quality of life. What is most important and essential for you? Would it be okay for you to be in a situation where you were living in an LTAC with a trach? Yes or no? I mean, those are really, some people are absolutely like, of course not. I would never want that. That's important information. And some people say, of course I'd want that. These are the things that are essential for us to distill and determine before, God forbid, you get sick, so that we know how to treat you and your family knows how to treat you vis-a-vis putting you on a ventilator, traching you, or disconnecting the ventilator. No one knows the answers to those questions unless you think about your own life and how you want to live it and make that clear to everyone around you so that it's not a guessing game. I guess, oh, well, there's still another slide. Wow, okay. Next one, whom to tell? Well, here's the thing, and Karl already talked a little bit about this. You've got to, if we're talking about things like ventilators and CPR, you're no longer with us, talking to us. You're with us, but you're no longer able to direct your own care. And that's where it's so critically important that other people really know your deep preferences and goals. And they can't know it if you haven't told them. And those people include the person you designate to be your surrogate decision maker on the advanced directive. And by the way, that doesn't necessarily have to be your wife or your husband. It has to be the person whom you deem most likely to be able to sort of do what needs to be done, stand up to all the stress and pressure of critical illness and of grief and of potential loss of you, and do the thing that's going to be most important for you, whatever that might be. So you pick the right person, you make sure that they're listed as your surrogate on your advance directive. You make sure that they understand all of the things about what's important to you in terms of your quality of life and all of your ideas about what you think about a ventilator and CPR, and make sure that that is clarified. If you are sure that you would never want to be put on a ventilator or have CPR, then those are things that I would write down on a POLST form. The POLST Physician Order for Life-Sustaining Treatment is a very, very important form, which is a doctor's order. Unlike an advance directive, a POLST is a doctor's order that says, do not intubate this person. So if a paramedic comes to your house and sees you struggling to breathe, they're going to know, all right, I'm not allowed to intubate this person, but I'm sure as heck going to treat their shortness of breath. I'm going to do everything I can to make them more comfortable. And that's what a POLST form is. It's for people who really know that they do not want certain types of interventions. Then you need to document that, because those things happen by default. That is what will happen by default, even against the will of those in your family, unless there is a document signed by a doctor that says, do not do this. Whew, I think, have I gotten to the end of?
You got a couple more.
Oh my goodness.
This one, I don't see. You can probably just skip this one.
What was that?
You can probably just skip this one and go to the summary.
Okay, let's go to the summary.
There's a couple of questions, Jess, just that you could maybe quickly answer, that had to do with the fact that people are requiring prolonged mechanical ventilation with COVID, like 2 to 3 weeks. Are most of them getting trachs? There was a question about whether these people are getting trachs or not.
Okay, good question. I will tell you the data. I was actually just looking at it this morning. The data are honestly quite grim about people who are intubated for COVID. Most of the data I have seen show, most of it coming out of the East Coast is we're talking 70 to 80% mortality. There are definitely people coming off the ventilators, and you're right that it's usually after a prolonged period of time, longer than we usually see with other types of pulmonary illness. But don't forget that in order to come off a ventilator, COVID or not, your body, and especially after prolonged intubation, your body, your diaphragm, remember, has gotten very, very dysfunctional. You're 3 weeks in, your body has, definitely gotten weaker and sicker, and whatever other underlying chronic health conditions you have have gotten, are going to already make you debilitated. So the people who are more likely to survive a prolonged intubation and come off and again, if lucky, return back to the quality of life that they had are not going to be not likely going to be elderly people who are have other chronic illnesses and cancers. That's not. I've already explained how ventilators weaken your body further and make the longer you're on them, the harder it is to come off. So I does that answer the question? I hope it does.
Yeah, I think so.
Was there another one there?
No, that was about the same type of thing.
Okay, so the ventilator summary really is just what I said. The COVID patients who require mechanical ventilation are not doing well, and if there are a few people coming off those ventilators, much less likely if you're frail, elderly, or with chronic illness or cancers. The SNF residents, again, very poor prognosis. Many people are saying that they wouldn't, that people who might have considered getting intubated, saying that with the COVID picture, if they are in those risk groups, they would just not choose to do an intubation. I think that, that summary really says. So the COVID-specific treatment idea is true. This puts a different, COVID puts a different spin to this whole thing because, and I'm seeing this now, patients really are staying on for a lot longer, and most of them are dying. Now, I've heard some conflicting data here in California that there's a much higher percentage of people who are surviving, and I've actually been hunting around for that data, and no one really knows. Why is it? Because if it's true, and I haven't gotten confirmation about that, but why would that be? Is it because the New York hospitals were so besieged and they had gastroenterologists running the ventilators, which is true, and you know, and because maybe there was a different strain? I mean, I've heard all sorts of theories. I don't know any answers to them, but I do think that in the age of COVID, I'm going to tell you, let me give you an example. A friend of mine who had a 92-year-old healthy father who got COVID, he had a pulsed form. I think I told you this, Karl, had a pulse form that said, do not resuscitate, do not intubate, got to a hospital in San Francisco, which shall not be named, and got intubated. I don't know what happened in that emergency room. I'm not sure. It was just at the beginning of the COVID, of what was happening in San Francisco. And at 2.5 weeks later, I got a call. Oh my gosh, what do we do? What do we do? And we had a long conversation, but I cannot imagine a 92-year-old man who is sick enough to be having difficulty breathing, getting on a ventilator, surviving, and he didn't. He was extubated and didn't. There was a case in New York of a 101-year-old woman who got COVID pneumonia, but she was not sick enough to be on a ventilator, and she wasn't on a ventilator, and she kind of got, I wouldn't say she got better, but she's still in the hospital, but she never got intubated. So I think it's the patients who are getting sick enough that they are requiring or considering ventilating them, where that decision really should be thought out in advance, because the likelihood of coming off that ventilator is very low.
Great. Let's see, next slide. And yeah, we're almost to the end here, and I've been trying to field questions as we go along, but if you have some questions, go ahead and type them in. So in section B of the PULSE, we talked about this before. There's a trial period of full treatment and this is when we changed it in 2014. It didn't used to have that. And so basically, if somebody wanted full treatment on a PULSE and subsequently didn't do well, and let's say they were in a persistent vegetative state, it created a conflict when the family said, no, let's pull the plug. I don't think she would want that. They're like, well, here's a piece of paper that says full treatment. So in my world, when people choose full treatment, a great majority of them pick trial period. They do not want to be kept on they don't want to be kept alive as a vegetable or whatever you want to say. And then the fact that we've got the box under selective treatment that says request transfer to hospital only if comfort needs can't be met. That's basically a do not hospitalize or do not transfer order. And for nursing home residents, especially right about now, it's something that more people are choosing, because this cruel pandemic where you can't have your family visit. Normally you'd send them to the hospital while the family would be at the bedside. Right now the family is nowhere to be found. The closest thing they have to family that is physically in contact with them is the nursing home staff, the CNAs who know them. They're in a familiar surrounding with people that they know and who know them. And so more people are saying, yeah, I don't want to be on a ventilator, so I just want you to do what you can here. And if I'm getting worse, just keep me comfortable here. At least I'll be, this is my home, essentially, for our long-term residents. Next slide. So just a few things to kind of wrap up. It's always important to, and Jess hit this very hard, is that everybody gets comfort care, right? So, even if you're not getting aggressive attempts to prolong your life, you're still going to get aggressive comfort care. And even if you decide you do want to be on a ventilator, yes, we're going to give you comfort meds. We're not in the business of making people suffer.
Karl?
Yeah.
Can I say a quick thing? Not only do you get comfort care, but you could get very aggressive medical care to treat your heart attack and whatever else is going on, if that's what is in your goals of care.
Absolutely. Yep. So anyway, the comfort meds we also talked about, and I know, Jess, you've had some experiences recently where you're in a hospital where there is no palliative care service and you're providing services, and they're uncomfortable giving a little dose of morphine to somebody who's severely short of breath because they're afraid about respiratory depression. And that's that's really a shame. We really need to do better than that, and we need to give people the opportunity to get the meds they need to promote comfort. So, mostly morphine, benzos, and the usual palliative care meds. I think that's something where we need to really make sure right now, when there's a lot of times there's not a lot of other things we can do. Again, the do not transfer may be appropriate for long-term care SNF residents. We just talked about that. Unfortunately, in California, if you're in an assisted living or residential care, do not transfer is almost impossible to achieve unless the person is actually on service with hospice because of Title 22. So if people really want to stay in place, probably the best thing to do is refer them to hospice so that they can do that, assuming that they have a 6-month life expectancy. And we may see more telemedicine sorts of evaluations and telemedicine palliative care interventions for people in residential facilities. And then last slide. I think we would all agree that it's more important than ever to discuss treatment preferences in advance because of COVID-19. It's always important, but it's even more important now because it does create some different nuances. And this is right now when people are living at home and, they're with their families a lot, whether it's virtual or in person, this is a perfect time for all of us to make sure that our advanced directives are up to date. CPR definitely is not likely to be effective in the frail population, and much less if somebody has COVID respiratory failure as the trigger for it. And DNR or no CPR does not mean just let me die. Some people get very aggressive, life-prolonging treatment, including ventilation, but if their heart stops, they don't get chest compressions. Everybody gets comfort care, and just to reiterate that our tools are available, and I put a couple of things in the chat box there about how to obtain either a print version of them or just to print them up on your own computers. Let's see. I'm going to look and see if we've got other questions. And in the meantime, Jess, anything to wrap up? We've just got a few minutes left.
No, I feel for everybody out there. Not sure who's out there, but this is, it's hard stuff. It's unpleasant sometimes to talk about, and it also feels confusing. And I'm sure it feels frightening to think, who are the doctors who are going to be taking care of me, and nurses, but who are they going to think about me as a human being? Are they going to really, honor what I say and what I write down and try to elicit from me what's important? And I'm hoping that they will. And I encourage everybody to really think about getting a palliative care consultation if you're not feeling like that's happening.
Yeah. So a couple questions that I think would be good for you. One, what palliative measures are most important? High flow O2 versus vent, prompt use of opioids for shortness of breath, weighing comfort versus respiratory suppression, and what should families be prepared to ask for? And then a question about the natural breathing rate and frequency being compromised by the ventilator and, the fighting and bucking of ventilator.
Yeah. Oh, wow. It's a lot of questions there. A lot of physiology questions. Oh, where should I start? The thing that I would start with is saying all of those things, high flow versus BiPAP versus the vent versus, how they're going to adjust the vent, what's your respiratory rate going to be, or, those all have to, there's a certain amount of faith that you have to have in the healthcare team taking care of you, that they're keeping up with the basics about what is recommended, which in this ever-changing environment, right, about what is the recommended approach to caring for someone who comes in with a COVID pneumonia in particular. It's a crazy, crazy moment in human history where we're kind of learning as we go. And I think that still, I wish I had easy answers. I think there is an easy answer to the issue of morphine or opioids and managing dyspnea, which I'm, seeing not being aggressively managed in some of the stuff I'm doing in New York, and that worries me. And I think that it's really important for families to be very proactive about particularly based on the goals of care. If the goals of care are, look, we understand that our mom is dying. We need you to make sure she is completely comfortable that dyspnea is being managed, anxiety is being managed, delirium is being managed, whatever might be happening. And it's hard when you're outside the hospital, because then you're really sort of disconnected from them. But I do think that that's certainly a very strong attention to, what are you doing for my mother's shortness of breath, which I know she must have because she's got COVID pneumonia. Those are the things that you can do to advocate. What's happening in terms of ventilators versus, high flow versus proning, et cetera, is, again, it's a little bit of a work in progress, but basically, as you've been hearing, people are starting to say, look, intubate later. There was a point where people were getting intubated very, very quickly, partly because the staff was worried about aerosolizing stuff, and I think that everyone's realizing that it's probably better to try to do other interventions, whether it's high flow, whether it's a lot of proning, as you've been hearing is happening, to try and get people through it without using a ventilator. And there's more and more of a desire not to use a ventilator on the part of the healthcare providers, but also as people are waking up to the potential life on a ventilator with COVID and the very low success rate, a lot of lay people are saying, I don't want this anymore. This is not what I want. And so, again, I hope I'm answering your questions, but I hope that answers your questions. There were a lot of questions in there. And if there's anything else, yeah.
Yeah, I think that was great. I do want to mention that there are also pediatric decision aids available. Thanks for that, Michelle. And we were asked to include some of the references that were, the web links and so on that were in the chat box. So hopefully we can do that when we send the follow-up email, Kita. And
thank you, Karl. Yes, I will do that.
Okay, and thanks to all of you for the work you're doing. And these are unprecedented times, and let's hope a lot of good comes of it when all is said and done. Amid the chaos and the devastation, especially in our frail, vulnerable, precious elders and chronically ill people.
Thank you both for being with us today and for sharing this wonderful information and these tools. Thank you all for participating, and we will get that information out to you in the follow-up email. Hope everyone has a great day.
Thank you.